Hey guys, welcome back to another USMLE question review. This is Dr. Singh again, and today we're just going to do a couple of questions on USMLE cardiology, and we're going to start it up. So let's go straight to the question stem. This is a lot of stuff on this page here, so don't be overwhelmed. But let's start. So, which of the following is the most appropriate next step in management? So, we have another management question here. Let's read it. So, a 44-year-old man comes to the emergency department 6 hours after the onset of increasingly severe substernal chest pain this morning. Okay. So, thinking of chest pain differentials in a 44-year-old guy, he says the pain increases when he lies down or coughs. He also has a 3-day history of chills, muscle aches, and fatigue. So when I see this, my assumption is when this guy's coming in for chest pain, they're showing us an EKG, is this, acute coronary syndrome like an NSTEMI or something like that, or a STEMI. But generally, pain increases when he coughs. That sounds like pleuritic chest pain. So now I'm thinking of cardio and pulmonary kind of issues, and then it's positional when he lies down. So that's also interesting. 3-day history of chills, muscle aches, and fatigue. That doesn't really sound like a precursor to acute coronary syndrome, but let's read on. He has hypertension and GERD. Medications are hydrochlorothiazide and omeprazole. He does not smoke cigarettes or drink alcohol. Interesting. So he's got a little bit of a fever, 100.4, borderline tachycardic, heart rate's 90, breathing okay, respirations are 18, and blood pressure he's normotensive. There is no JVD, rash, or organomegaly. On cardiac exam, a scratchy sound is heard over the left sternal border. There is a regular rate and rhythm and no murmurs. So really, this scratchy sound is kind of giving it away that this is a friction rub. So when you see a friction rub plus pleuritic pain, worse when lying down, so presumably better when he leans forward, this smells like acute pericarditis. Especially, it's 6 hours, so it's very acute, always looking at the time course. And then 3-day history of chills, muscle aches, and fatigues. This sounds like a preceding kind of viral illness. So this sounds like a acute viral pericarditis. Let's see what the labs show. White count is 11,500. So, a little high. Normal is, let's say, between 6,000 and 10,000. So a little high. He's got elevated erythrocyte sedimentation rate, so of 45. Anything more than 15 or 20 is high. So he's inflamed. Let's say his inflammatory markers are up. That kind of fits the picture of acute pericarditis. Now, people that kind of freak out about EKGs, not to worry. We pretty much answered this question, or at least know the diagnosis without the EKG. But let's look at it. So, you can methodically read the EKG, like they teach us, in residency in med school, rate, rhythm, axis, interval, that sort of thing. Or you can just kind of go start looking for abnormalities straight away, which is what I'm going to do here just for time's sake. And so I'm looking at the anterior leads first. And so I see some ST elevation here, V2, V3, a little in V4. And then I'm starting to notice, okay, so the ST changes don't fit a particular pattern because all of a sudden it's V1 through V6 all have a little bit of elevation. And the inferior leads are also a little elevated. So 2 in AVF I see, and 3 honestly are elevated. So we're calling this diffuse ST elevation, as well as some PR depression here as well in V2, V3. So those are pretty prototypical EKG changes for acute pericarditis. Now, in some questions, they might just give you the EKG without all of this information. So there's a lot of history in here that suggests that this is pericarditis. So I guess the way to differentiate if there was only an EKG would be, okay, if is this an MI or pericarditis? Well, an MI would be, a grouping of certain leads that represent a certain part of the heart, right? So the inferior wall of the heart would be 2, 3 in AVF. but you wouldn't necessarily see that in the anterior, the anterolateral leads as well. So when you see all the leads or many of them, I would call that, that's diffuse ST elevation concerning for pericarditis. So, okay, so all roads lead to pericarditis. Which of the following is the most appropriate next step in management? Okay, so answer choice A, cardiac cath. So the point of a cardiac cath is if the guy's having a heart attack, do we need to go in and put in a stent, essentially, right? And so I don't think he's having a heart attack, nor does he need a stent. So cardiac cath is out. Cardiac MRI, let's hold on to for a second. Let's go to see CT pulmonary angiography. And so knowing what these diagnostic tests are best for will tell you, just thinking about when you think of CT angiogram, what's the main diagnosis that you should be thinking of? Well, generally, it's pulmonary embolism, PE. Obviously, you can use it to look for aortic dissection and that sort of thing, aortic aneurysm as well. But, pulmonary angiogram is not going to help us with pericarditis, okay? D, echo, we can hold on for a second on echo. And then exercise treadmill stress test. So treadmill stress test, you would assume in someone that has some sort of angina that you want to check and see, do they have, appropriate stress response? Do they have ST changes on their EKG when they exercise that leads you to believe it's angina? And that would take you down that pathway. So exercise stress test in pericarditis is very useless. So echo versus cardiac MRI. Echo is going to be the right answer in this question, so letter D. And really, do we absolutely need an echo for this guy? I don't think so. We have the diagnosis. We could go ahead and treat straight away, but an echo is useful in these people because you'll be able to see whether or not this guy's got a big old pericardial effusion. And so that could be useful for that regard. Cardiac MRI is a kind of an advanced test. You would never really do that first. Cardiac MRI you could use to kind of delineate certain types of myocardial scarring, looking for healthy versus unhealthy myocardium and that sort of stuff. So not really useful in this scenario. And never pick MRI as your first test if you have a list of tests to do as far as cardiac studies go. That is the video. There is a second part to this question that we're going to do in the next video, just because I don't want to make this video too long. So just stay tuned for the next video. I'm just going to record it right now. I'm going to try and post the two right at the same time. So we'll see you in the next video. Thanks, guys.